Okay, good afternoon, everybody. Good afternoon. My name is Craig Harms, and I serve as the director of the School of Health Sciences in the College of Health and Human Sciences. And it's my great pleasure to welcome you to the presentation of our Career Impact Award winner, Dr. Sara Bonus. We've kept Sara busy the last couple of days interacting with individuals, groups, and classes, and we very much look forward to her presentation this afternoon. Following her presentation, there will be a time for a few questions and answers. We do have a mic that will pass around. I strongly encourage you, if at all possible, please don't simply get up and leave because the noise level gets loud for those questions. So stay seated. Again, there'll only be time for a few questions, so it won't go really long. Afterwards, I encourage you to stick around. Down below, we'll have a reception in the back of the room. You're invited to stick around for that, have a few refreshments, and interact with Sara if you'd like to. So, by way of introduction, Dr. Sara Bonus, Professor of Medicine, is the Medical Director of the Healthy Longevity Clinic at Mayo Clinic in Rochester. She is board certified in internal medicine and lifestyle medicine. She is also certified as a physician nutritionist specialist. Before starting her medical training, she pursued undergraduate and graduate training in nutrition at Kansas State University in Human Nutrition, so she's one of our own. She completed her medical training at the University of Nebraska Medical Center before moving to Rochester for residency and chief residency. She has been on staff at Mayo since 2014 and continues to practice in general, internal medicine, integrative medicine, and nutritional clinics. Throughout her medical career, she continues to incorporate her nutrition and lifestyle medicine expertise into care of patients with a wide variety of health concerns and interest in preventing chronic diseases. Given increased patient interest in how to improve their health span, she is working with a multidisciplinary team, including dietitians, exercise specialists, pharmacists, resiliency experts, and researchers to provide clinical care that utilizes an individualized, patient-centered, evidence-based approach to healthy longevity and unique patient needs. She also practices at the Mayo Home Parental and Eternal Nutrition programs, providing care to patients with intestinal failure needing long-term advanced nutritional support. She continues to be active in research and publishes work in both of these areas. Please join me in welcoming Dr. Sara Bonus.
Thank you, Dr. Harms, and thank you to all of you for being here this afternoon. I recognize faces from classes, from my time here, from students I've met over the last few days, family and friends, and it's always good to come home. Certainly, I know a place I love full well, and it's good to return to K-State. So, appreciate the honor and pleasure. Who here likes food? All right, let's talk about it. Who starts a talk with a picture of a strawberry? All right, let's take a minute. Let's talk a little bit about the different roles of food. Those of you who have known me for a few years know that strawberries have a special place in my life. My parents are here, my sister is here, some family friends, and you will know that strawberries have not always had a loving role in my life. Growing up on a hobby farm near Manhattan, one year we picked 1,000 pounds of strawberries. There may have been some grumbling. It was not always thought of well. Now in the longevity realm, one of the researchers looking at quercetin, if you've heard of this, it's supposed to be one of those functional foods highly found in strawberries. It's on the buzz. If you want to live forever, eat your strawberries. But let's go on a thought exercise. So this summer, Here with my husband, visiting my parents, you know those hot summer days in Kansas, right? It's 90 degrees, it's the end of the day, it's dinner time, there's strawberries that are ripe. I'm having one of those reflective moments, and let's go down memory lane. What's better at the end of a hot summer day than a bowl of fresh strawberries picked right out of the garden with some warm strawberries with fresh vanilla ice cream? So let's go out to the garden, my sister, my husband, my dad. The sunshine, the grass has been mowed, so you can just smell that grass in the air. There's a breeze. You're out there, it's warm. You pull aside the strawberry plant, there's a little bit of a prickle. You can feel it. You can smell a ripe strawberry. I don't know if you guys have really experienced a fresh ripe strawberry, but try to smell that strawberry. You see the red, you pick that strawberry, it's a little bit soft. If you can really look, it doesn't project, but there are tiny hairs on a strawberry. When was the last time you really felt a strawberry in that tiny little fuzz? You pick it, you smell it. Oops, this one has a bad spot. Your sister makes a snarky comment, so you throw it at her. It may have happened. The next one, perfect. It's a beautiful one. It goes in the bowl. You get your bowl of strawberries, you go in, you're in the kitchen, you wash them off. You're talking about the day, you're preparing them, you have your bowl of strawberries, you sit down around the table, you're talking about plans for the next day. There's something about that bowl of warm from the sun, fresh strawberries, that vanilla ice cream, talking about the day, hearing about what's going on, etc. So certainly we've had food, we've had nutrition, we've had our phytochemicals, we've had our calcium, we've had all of these other things. But we've had social connection, we've had a meditative experience, we've had preparation for the rest that we're going to get with sleep, we've had laughter, we've had so many other things. Food is more than just nutrition. There are so many other aspects to what we put into our bodies as opposed to just a source of fuel and nutrition. And so I think about food as not just the chemistry or the nutrients, but that connection, a way of stress reduction, a way of meeting so many other aspects. And so that's the discussion here for what is food? Can it actually be medicine? And how does health begin at the table? The table is more than just a place to eat. Food is more than nutrition. But certainly these both play a role in how we can promote health and well-being, and that's part of our journey here. So as we talk about this, the opinions today expressed are my own. This presentation is not intended as medical advice. Anything you take away, please discuss with your healthcare team. And certainly I believe that lifestyle medicine and healthy lifestyle habits are important, but don't replace traditional medical care, but the two should complement each other. If you haven't noticed, October is Health and Well-Being Month, and so there's a lot of signs on campus. I had the pleasure of meeting with a lot of great faculty across the institution yesterday and today, and applaud K-State as a health-promoting university and all of the advances and steps it's taking to promote not just financial literacy, but the physical activity, social connection, really putting health promotion into its policies and all of the different aspects that it's doing. I probably don't need to tell the students that Friday is Wildcat Pause Day. But would encourage you to make sure that you're trying to utilize all of the different aspects that K-State is putting forward for you now to build those habits as you go forward. so that you can build these habits while you're young and carry these forward as you go on into your careers. I had the pleasure yesterday of meeting with several of our representatives from the Exercises Medicine Student Organization and other groups. And if you haven't checked them out, do so. Look for ways to get involved, for ways to connect, and certainly one of these key aspects for promoting health is exercise. But as we talk about exercise is medicine, one of the corollaries is, how can food be medicine? And how do we tie these two together to really put things and optimize our health? We'll talk a little bit about resources first and then go into the data, because the data can sometimes lose folks. But I wanted to give you a resource to take away for those who are interested in podcasts. Dr. Christopher Camp is one of our orthopedic surgeons. He's a sports medicine physician at Mayo. And I really appreciate his approach with the Human Optimization Project. He really looks at the approach from James Clear. How can we be 1% better each day? As we talk about lifestyle change, as we talk about trying to make any changes, the data would certainly suggest that going from sitting on the couch and doing no exercise to a goal of running a marathon is less likely to be successful than going from sitting on the couch to let's go for a short walk and let's make a small incremental change. When I've talked with Dr. Camp, one of the other things that he really emphasizes is hearing folks talk about supplements is a common one. Everyone wants to know what supplement or what pill, or should they eat that cup of blueberries, will it really make them live a year longer? Instead of focusing on how many servings of fruits and vegetables should I eat in general, instead of what's the fruit or vegetable that I should eat. He talks about focusing on the pennies, and that's what people tend to focus on, instead of the dollar bills. What are the most bang for your buck? What are the biggest things that we can do that are the most effective, instead of focusing on the details? He's got a ton of great faculty that he interviews on this program, and I appreciate his focus here that we feel the need to do more, but we feel the need to do less. And how can we wed those two together? So as you're looking for podcasts or other things, I would encourage you to check out some of his resources. I am not the person he talks to on this podcast about nutrition, but he does talk to Tara Schmidt, one of the Mayo dietitians, and she's wonderful. So food is medicine. This is a U.S. Department of Health and Human Services initiative. Part of it is looking at ending food access issues. But part of it is also looking at how do we help decrease the chronic disease issues that we have in the US? We'll look at that data here in a little bit. We'll dive more into research that shows food is medicine and how diet ties into a lot of the chronic diseases that we're facing issues with here in the US. And I don't know which schools we have represented here, but as we look, many of you may be health professions rising, College of Health Sciences. How many we have represented? All right, we've got a few. So a few health professions, aspirational individuals. If you're interested, the American College of Culinary Medicine, healthcare professionals, chef, food service professional. You can get certified. There's didactic information on nutrition education. You actually take online Zoom cooking classes with a chef and a dietitian. You have to learn knife skills and how to chop and dice and saute and all of these things and do interactive sessions together. For those not potentially interested, but who eat. We verified that folks like food. There is a whole section here on recipes, and you can sort by different dietary needs. So lifestyle medicine. What is lifestyle medicine? Healthful eating. And I was talking to some of the faculty earlier today about healthful eating and nutrition. I think food ties into every college. We talked here about nutrition and the health and human sciences. If we talk about ag, do we have any College of Ag out here? All right, we're gonna pretend that they're, oh, okay, I see you, woohoo, way to represent College of Ag. We're farming, we're gonna be growing that food. Grain and milling science, okay, we need some of those. We've got to grow the food, turn it into healthy bread, grind that grain. The vet school, taking care of animals. Okay, nope. They're off taking care of their animals. Business school. All right, billions of dollars. Food is a billions of dollars industry, right? I know just the gluten-free market continues to grow and grow. I'm not advocating that everyone should be gluten-free unless you need to be, but billions. We don't have time today to dive into the psychology and sociology of food, but guilt, reward, pleasure, these all tie into our food choices. Do we have our psychology, sociology folks out here? Okay, yes. If you figure out how we figure out food choices and the risk, reward, pleasure of all of the food choices that we make, come tell me so that we can figure this out together and change the world. Education. All right, woohoo, okay. That's part of that education reward, right? We teach kids, man, how often grapes or crackers are used for counting. We can build stuff with them. It keeps them quiet. Food is in schools, right? Chemists, none of them. Oh, okay, perfect. Cooking is chemistry that's edible. Prove me wrong. The Maillard reaction, baking soda, carbon dioxide water, right? Leavening agents. And I'm gonna guess we don't have any engineers. Do we have any engineers? All right, this is the best one. Who has not made a marshmallow toothpick bridge? Food is in engineering, and they missed out. So just tell them that. But food covers, I know I missed a ton of majors in schools, I'm sorry, but food is in everything, right? And so as we talk about healthful eating, that's where we're going to be going. But physical activity, certainly we talked about exercise medicine. We'll touch a little bit of managing stress, the psychology, sociology aspect. Food is a key part of relationships. We have Thanksgiving coming up. We have Christmas. Food can add to stress. Food can be a way to decrease our stress there. Food probably does impact our sleep, and we'll talk about risky substances as well. This is a slide from the American College of Lifestyle Medicine. If we go back to the early 1900s, our major causes of death here were infectious diseases. And so with vaccinations, with antibiotics, really our infectious disease mortality declined significantly. As we had a lot of our wars in the earlier part of the century or the last century, infectious diseases were actually the leading cause of mortality during those conflicts. So we've made great progress, but now we talk about non-communicable diseases as what is the leading causes of death. As we've made this progress here, our pyramid has shifted. So in the 1960s, we were a fairly young nation, not just that we were overall a younger nation, but our population in general was younger. significant proportion of the US was less than the age of 25. Now we are living longer, but that comes with chronic diseases that we tend to develop as we get older. As we look at life expectancy in the US, one of the biggest predictors of life expectancy in the US is actually zip code. And so this is a map of life expectancy with the red being the lowest life expectancy, about 59 to 75, and the dark blues being the highest life expectancy. This graph from the Census Bureau is household income. Red is again the lowest household income, and dark blue is the highest household income. We also know that education, access to health care, access to other things also correlate with our life expectancy. So there are many factors that are associated with better life expectancy. Across the globe, life expectancy, we are making gains. So this is looking from the year 2000 to 2019. On the top, you can see life expectancy across the globe has gone from 68 or so up to about 73. But the bottom is health-adjusted life expectancy, so the number of years we're living in good health. And you can see that although we're overall living longer, we are living some of those years, more of those years in good health, but this graph over here on the bottom shows how we're doing in the US. And if we look down here at the bottom, you can see that our health-adjusted life expectancy in the US is actually trending down. So we are being unhealthier for longer in the US, even though our life expectancy in the US has plateaued. So we are living unhealthier for longer in the US, which is unfortunate. So I was asked this morning by a student what I thought the leading causes of death in your generation, this college-age generation, would be. And I said, I don't see any indication that it's going to change from heart disease or cancer because they're leading the pack so greatly. So it takes a while for all of the mortality data in the US to be updated, but this was the most recent data from CDC. And you can see how significantly heart disease and cancer are the leading causes of death in the United States. We'll break down the top 9 of these because the majority of these are what we would consider non-communicable diseases, right? They're not infectious causes. COVID down there at the very bottom in number 10 would be a communicable disease. Some people are concerned that the healthcare system has it all figured out and we are holding back from the public the secrets to great health. This just came out last month. It was specifically looking at mortality among surgeons in the US, but if you look down here at the bottom, we have surgeons, other physicians, lawyers, engineers, and scientists. So that's a lot of you in this room here who are training, and then all other workers. They ran their data a little bit differently, had different age parameters, not including everyone, and so their 1 and 2 are flipped from that last slide, but you can see 1 and 2 are still cancer and heart disease. Number 3 is still unintentional injury. I would suggest that as healthcare professionals, physicians and surgeons probably do have a little less tobacco use, and so respiratory diseases are lower for us. Diabetes is a little bit lower, particularly among the surgeons. But in general, it doesn't look like we have it all figured out. And you can see suicide here, number 3. For the other physicians, we certainly don't have mental health care figured out. I'd also say our surgeons need to figure out driving safer. So, food as medicine, how does this all tie into diet? And looking at the Health Promoting University, there are Mediterranean diet guidelines and Mediterranean diet classes coming up. I absolutely agree the Mediterranean diet is a healthy diet. I have information here about the dietary guidelines for Americans, but I'll talk a little bit about the overlap between those two and how I think even dietary guidelines for Americans, the Healthy Eating Index, can be used to promote a healthy diet here. And so how do they come up with the dietary guidelines for Americans? And certainly there is evidence to suggest that following the dietary guidelines for Americans, the Mediterranean diet, the DASH diet, many of these different diets can promote health and can certainly reduce the risk of many of these leading causes of death that we've talked about. It's quite a process, actually, for the dietary guidelines for Americans. And they put out a call, they have a whole committee, they review this, they have scientific experts, there's actually a public comment period, and then they have clearance again by the USDA and Health and Human Services. If you haven't looked for a while, it's no longer a pyramid, it's the plate method, focusing on whole fruits and vegetables as opposed to fruit juices or veggie juices. More than half of your grains is whole grains. Vary your protein. And then dairy, whether it be low-fat dairy, soy, or alternative dairy sources. I get a lot of questions about what's the best diet. And what I see consistently through the literature, whether it be the Mediterranean diet, the myplate.gov, the DASH diet, the MIND diet, which is a combination of the Mediterranean diet and the DASH diet, designed to reduce cognitive disease or dementia. It's focusing on whole grains, fruits and vegetables, limiting fat, salt, and sugar, and limiting processed foods. So those are the consistent patterns across all of those. If you want to know how you're doing, there's a lot of assessment tools. We'll talk about several slides showing how performance with these is associated with health outcomes. If you want to go home and assess your healthy eating index score or how you're doing, these are the websites and the scoring parameters for the Healthy Eating Index. There's probably an app or an easier website to do it, but these are the scoring parameters. In general, how is the US doing? I usually think we're pretty competitive, but our average score for how we're doing on the Healthy Eating Index is about 59. Less than 50 is considered inadequate. Greater than 70 is considered optimal. So we're getting about a D. C, D. This was a modeling study done in Europe looking at how many years of life expectancy could we gain if we did an optimal diet versus a feasible diet. So as we talk about incremental gains, right, and 1% better, if you wanted to choose one thing and say, I'm going to focus on increasing my fruit or increasing my vegetable, choose one of these, and one change could really make a difference in you and your life. One of the other most common questions I get is ultra-processed foods. There's a big buzz. The US does not have a scoring system for ultra-processed foods. Europe does, South America does. The most common one used is the NOVA system. If you want to learn more about the ultra-processed food scoring system, this world.openfoodfacts.org is a nice website where you can actually type in food products and it will give you not only this nutrition score, which is this Nutri-Score over here, very good nutritional quality, but it will give you this NOVA score, which is a processed food score, and also this green score, which is how environmentally friendly is this food product. So what is this food processing score? So NOVA 1 is an unprocessed or minimally processed food. Think of an apple. That's a NOVA 1. NOVA 2, it can contain culinary ingredients. It may be like a dried apple, so it's a little bit processed, but predominantly whole. NOVA 3 may be canned or processed a little bit more, like applesauce. And then NOVA 4 is what we talk about with that ultra-processed, namely those ready-to-eat sorts of things, so like an apple pie bar or an apple granola bar. That's where we get to that ultra-processed classification. So as we look at ultra-processed foods, in the US, if you're interested, for youth in general, we're about 60% of our calories from ultra-processed foods. For adults, we're about 50%. You can see the trend is down just a little bit there. I thought this was an interesting one because as we look at the top caloric contributions of ultra-processed foods, I think most of us consider sandwiches a fairly healthy option, right? But that tends to be the top contributor of ultra-processed foods. But if you think about lunch meat or cheese, those are both going to be considered an ultra-processed food product. It doesn't always mean that everything is going to be unhealthy. There's going to be healthier versions as compared to unhealthier versions, but these are the top ultra-processed foods. As we think about those in conjunction with a diet, this was college students in Rhode Island, and looking at this bottom here is the percent of energy from ultra-processed foods, and so as that percent of energy from ultra-processed foods went up, their healthy eating index score went down. So the more ultra-processed foods that you have, overall your diet quality tends to go down. I hear a lot of questions too about an anti-inflammatory diet. And people want to know, they're trying to follow an anti-inflammatory diet, and what does that mean? My bottom line summary is that an anti-inflammatory diet is a diet high in fruits and vegetables and whole grains and low in salt and fat and sugar and processed foods, which is a Mediterranean diet or a DASH diet or any of the other healthy diet eating patterns that we have talked about. So this slide just shows that if you're following these other diet patterns we've talked about, your anti-inflammatory diet score correlates highly with those others. From a sustainability perspective, these whole food diets also are more environmentally friendly. We're going to have less carbon footprint, less processing with any of these food patterns as well. The Eat Lancet Commission was tasked with looking at environmental sustainability of all of these different diet patterns, and this is what they came up with as well: predominantly plants, some animal products, but eating a variety, etc. So how are we doing on all of these things as Americans? The bottom line is it varies. This hashed area above is what we're consuming above the recommended amounts of. You can see we're knocking it out of the park with refined grains. We're doing really well with meat, poultry, and eggs. Pretty good here with milk and soy. Or sorry, that's nuts, seeds, and soy. But you can see we're quite low here with our vegetables in general, our fruits, and our whole grains. If you're a map person, this is a graphic from the American College of Lifestyle Medicine. Kansas is doing decent, but we're still only about an average of 1.6 servings a day of vegetables. California and Oregon are beating us pretty handedly over here on our vegetable consumption. So why do we pay attention to how we're eating and how this all correlates? If we really look at it, having a higher healthy eating index or DASH diet score is associated with a significant reduction in all-cause mortality. And so if we do want to live longer, live healthier, then what we do eat does make a difference. Now, this doesn't adjust for all of the other medications and other things, but diet does play a role in our health. And so we'll talk a little bit more about how it's associated with a reduced risk of heart disease, reduced risk of type 2 diabetes, reduced risk of cancer. We won't go into so much obesity or hip fracture. So heart disease, again from that same study, highest diet quality, and choose whether it's the dietary guidelines for Americans or the DASH diet. Following these diet patterns, there are similar graphs for the Mediterranean diet, but following fruits, vegetables, whole grains, low salt, low fat diet is associated with reduced risk of cardiovascular disease. The American Heart Association, American College of Cardiology has what they call their Essential 8. And these cogs in here represent a healthy diet, which in their studies was the DASH diet, the healthy eating diet, or the Mediterranean diet for those in America. Also physical activity, so don't forget your exercise is medicine team. Healthy sleep, healthy weight, healthy cholesterol, healthy blood pressure, healthy blood sugar, and avoiding nicotine. So it goes a little beyond your K-State health promoting university, but a lot of similar parameters. Down here at the bottom, though, it ties in nicely with structure and systems, the community, and so what K-State is doing from a social connections perspective, that institutional and organization, certainly K-State is getting behind that. Interpersonal, those connections, that community, those other things. And with Pause Day, that psychological health piece that they're trying to build. Psychological well-being, mindfulness, gratitude, trying to decrease the anxiety, anger, hostility, chronic stress, depression. I think this is a pretty telling sign with the higher DASH diet score or the higher adherence to a DASH diet, significant reduction again in your risk for cardiovascular disease or coronary artery disease, those blockages in the arteries to the heart. Again, adherence to the DASH diet associated with a lower risk of heart failure. So again, multiple different types of heart disease, and all of them adhering to more fruits and vegetables, more whole grains, lower salt, all of these things, using that dietary component as part of your medical therapy to try to prevent these risks of heart disease. As we look at cancer, certainly another leading cause of death, number 2, this paper, multiple studies all associated with highest diet quality, showing significant risk reduction or reduced risk of developing cancer. They actually break it down into the different types of cancer if you want to look at this paper in detail for prostate cancer, esophageal cancer, colorectal cancer, etc. But multiple different types of cancer with significant risk reduction. As we talked about, we went over the pillars of lifestyle medicine, and as we look at the World Cancer Research Fund, all of these societies really say a lot of the same thing. Healthy weight, physically active, eat a diet rich in whole grains, vegetables, plants and beans, fruit and beans, Avoid fast foods. We talked about our processed foods. Limit consumption of red and processed meat. Avoid sugar-sweetened beverages, or limit those. Limit consumption of alcohol. Don't use supplements for cancer prevention. This one talks about breastfeeding. And then if you are diagnosed with cancer, follow up with your cancer care team. Unintentional injury and chronic lower respiratory disease. This one's a little bit more difficult, but back when I was a student here, we were still working for Students for Clean Air Manhattan. The goal there was to get cigarette smoking out of the restaurants in town. I don't know how many of you in college right now even remember if there was cigarette smoking allowed in any restaurants when you really have been alive. But that was our public health initiative at the time. The acronym was SCAM. If you play that out, Students for Clean Air Manhattan, SCAM, so maybe not the best acronym, but certainly a public health initiative to try to address chronic lower respiratory disease. Still on the top 10 leading causes of death, so we're not quite there, but making progress. As we look at unintentional injury, poisoning is number 1, and then motor vehicle traffic deaths. I'm gonna use this as my plug for poisoning. Alcohol poisoning counts as poisoning. Use alcohol wisely. I know you are at a time in your life where we are just starting to experiment and enjoy alcohol, but make smart choices. And for motor vehicle traffic deaths, don't use your cell phone while you're driving. This applies to our college students and to everyone else in this room. That text, that cell phone call, those other things can wait. That person will be there when you get to your destination. If you really need to talk, text, whatever, please pull over to the side of the road. Having seen a lot of people on scooters, I will also say don't scoot and use your cell phone. That is also a very hazardous behavior, in my opinion, as a physician and as a pedestrian. So, alcohol would be the risky substance in here, but those are my personal plugs for avoiding unintentional injury and nicotine. I would include vaping. Any form of nicotine is associated with generally poorer health outcomes. And so I would avoid all of those substances which I would consider risky and behaviors which I would consider risky. Stroke, and then they say Alzheimer's, I lumped it in as overall dementia. I really like this graphic here from the World Health Organization. As we talk about, this one is more about exercise, but certainly diet plays a role, and we'll talk about that a little bit on the next slide. I think we sometimes forget that generally it's thought that about 1/3 of dementia cases are attributable to modifiable risk factors. And so certainly not all, but that's a significant amount. And when we talk about, I feel repetitive in this talk, but what's good for the heart is good for the brain. So a lot of these major organizations, the Cancer Society, the Heart Society, the Brain Society, these things are all good at preventing each of these shared conditions. How much exercise is recommended? We have our exercise specialists, our kinesiology majors. They'll probably come up afterwards and talk about 150 minutes and weight and resistance training, all of these things. I know these are more general guidelines, but as we talk about dementia prevention, as we talk about a start, they talk about an aerobic 2 a day. So for dementia prevention, 10 minutes of moderate activity twice a day. So it's not going to add up to your total, but it's at least a start. Something is better than nothing, and 10 minutes, that's not being on your scooter and walking to class. So you do that twice a day, walk to class and back to the dorms. There's your dementia prevention. You got it. Continue that when you graduate, you're good to go. Resistance training, twice a week. And so certainly there are other health benefits if we continue this on in higher amounts, but this is a great place to start. And then we have a summary of where this evidence comes from. As we talk about tying this in with diet, we know that diabetes is a risk factor for dementia. We know that there are genetic predispositions. There's a similar graphic. I know this is busy, but the American Neurology Association talks about life's simple 7, and that's right in here. And those simple 7 talk about moderate alcohol consumption, diet, physical activity, maintaining healthy blood sugar, less sedentary activity, blood lipids, cholesterol, et cetera. And by maintaining those healthy lifestyle factors, even with a genetic predisposition, we can reduce our risk of dementia. So with lifestyle factors, even with predisposing factors, we can help reduce our risk of cognitive disease. Diabetes is certainly prevalent and a major health challenge in the US. And so with these, there's the Healthy Eating Index. Any of these dietary programs, again, were associated with a risk reduction in the risk of type 2 diabetes. As we talk about other programs in lifestyle and diet, this is from the American College of Lifestyle Medicine, but the study was done several years ago with the Diabetes Prevention Program. And this was looking at a randomized trial with individuals, 3,000 individuals at risk for diabetes based on elevated fasting glucose. They were randomly assigned to placebo, metformin, or lifestyle. Now, lifestyle did include dietary changes, follow up with a health and wellness coach, as well as diet changes and exercise. And the lifestyle intervention in the beginning was more effective than the metformin or the medication. Over time, they did come together, but certainly lifestyle interventions were significantly beneficial in reducing the risk for diabetes over several years or delaying that onset of type 2 diabetes. Kidney disease was number 7 in our leading causes of death. The top causes of kidney disease in the US are diabetes, which we just talked about, and high blood pressure, which is a cardiovascular disease. Diet is closely related to both of those conditions. And so by changing our diet and reducing our risk of diabetes and high blood pressure, we can certainly contribute to a reduced risk of kidney disease. The DASH diet, the dietary approaches to stop hypertension. Hypertension is our fancy term for high blood pressure. So that's a diet there specifically designed to reduce high blood pressure. We reduce high blood pressure, we reduce our risk of kidney disease. If we have kidney disease, nutrition is one of the mainstays of trying to prevent progression of kidney disease. And so kidney disease is actually one of the few conditions, if you have bad enough kidney disease where everybody's required, in essence, to meet with a dietitian. I don't know where our dietetic students are, but you play a key role in their future health. Liver disease and cirrhosis. I know the US likes to be competitive. ALD stands for alcoholic liver disease. I don't know that the US wants to win the gold in alcoholic liver disease. We are leading the pack in our rates of alcoholic liver disease. So going back to that, avoiding risky substances, using alcohol responsibly, etc. Our rates of alcoholic liver disease have gone up significantly since the pandemic. These are going up significantly worldwide in the peri-pandemic period. There are theories around isolation and the social changes that have happened with the pandemic or after the pandemic. I guess I could say to the student who asked this morning what the leading cause of death will be in your generation, if we don't stop this, liver disease could rise. So let's fix this, you guys. This is in your hands. MASLD is metabolic-associated liver disease. We're not leading here, but we're in the middle. Metabolic-associated liver disease is associated with impaired fasting glucose, insulin resistance. Again, all of those things associated with our rising insulin resistance, diabetes, and other things, also on the rise worldwide. Metabolic liver disease has gone up from 25-ish% to about 54% across the globe. So that's not heading in the right direction and certainly going to be a global challenge. It's a significantly rising cause of liver transplants across the US right now. So lifestyle medicine, we've just had a depressing chat, right? All of the causes of death, top 9, not the best things, but how diet can impact all of those. These two studies, as we talk about evidence-based medicine, the top study here was published in 2018 in the Journal of the American College of Cardiology. And if you made it to age 50 in the US, if you are a female over here on the left, a male on the right, women in general live longer than men. But if you did 0 of these lifestyle factors, you did all 5 of these lifestyle factors, how many years on average of life did you have left? So 3.5 hours of moderate to vigorous activity, a high quality diet as assessed by the Healthy Eating Index, never smoking, moderate alcohol intake, and a normal weight. I realize for about 80% of the audience, you're not anywhere near 50, but if you're somewhere near 50, this is some data relevant to you. But fairly simple factors. If you go to the publication, there's actually graphs for each of those different components, and you can kind of see, okay, what are the things I may prioritize for my health moving forward? But as we talk about lifestyle medicine, these are the components that have borne out over time. This bottom graph, as we talk about evidence again, did it show up in more than one study, more than one time through time? This was published in 2024 in the American Journal of Clinical Nutrition. This was from the Million Veterans Project. This was individuals at the age of 40, so getting closer, but still significantly older than most of this audience. And they looked at 8 lifestyle factors: plant-based diet, never smoking, no binge drinking, no opioid use disorder, a different measurement activity measure, but still similar activity. Social connections, again, looking at different things. And their measure was, if you have a bad day, do you have someone to give you a hug? If you're sick, do you have someone to get you groceries? So is there someone in your life who you can rely on? No anxiety or depression was not that you've never had these things, but are we managing them effectively? Whether it be diet, whether it be lifestyle, whether it be medication, whether it be counseling, therapy, etc. But are we managing these? And sleeping 7 to 9 hours a night. So these factors, lifestyle factors, have borne out time and again to be associated with increasing your lifespan. Relationships, one of the pillars, we talk about social connections as a health promoting university. We talk about social connections with lifestyle medicine. Social connections just showed up there in the Million Veterans Project lifestyle assessments. Family meal times, I put family in quote. I couldn't find a study about family on college campuses, but we know family with a nuclear family has been associated with cohesion, a sense of belonging, emotional security. For one of our sociology majors, health and human sciences, I think it would be an interesting study for those, whether it's roommates in the dorm or somewhere else. If you eat together with a group of people who care about you and talk about your day, I do wonder if you have better academic performance and a better sense of belonging and better fruit and vegetable consumption. I do believe that mealtime can be a way to manage stress, take some downtime. I tell residents to actually sit down for meals if possible. As physicians, we sometimes eat standing, eat on the go, don't take time for ourselves. I know college students may do the same things. Other people may too. But take a little time and actually sit at a table. Take time to connect. There are actually meditative exercises for food. A common one is with a raisin. Sounds great, right? Close your eyes. Imagine a raisin. Eventually, you're supposed to put the raisin in your mouth, taste it, feel it, do all of these things. You don't like raisins, I can tell. I see your face. Yep. Okay. So choose a dried fruit that you do like, but actually take some time and think through that. And instead of rushing through it, make food a thoughtful experience. I am not familiar with this program, but this is supposed to be a meditative experience for kids in the classroom through this Minnesota Ag classroom, and I would be curious as to what all they're doing. For our education major in the back, check it out. I'd be curious what you think. This is a quick graphic, and I told you already to check out the exercises medicine group, but think about ways to increase your physical activity. Even a few steps can make a difference. Physical activity can help you manage stress. It can help you improve sleep. It can help with so many different aspects. So as we get to the end of our hour, and we talk about our 6 pillars of lifestyle medicine, we've talked about how diet plays a role in so many of these top leading causes of death in the US. So think about how you can make 1% better choices. What's one thing that you may be able to do from a diet perspective to make a change? And don't let one small setback ruin tomorrow. I had Dole Whip with my family last night. I still eat ice cream. You can enjoy all sorts of different things, but eat your fruits and vegetables too. Think about how you can work on that physical activity. Think about how you can take time to reflect, mindful meditation, address your stress, decrease that anxiety. Take time for social connections and building those networks. I have patients who tell me they will sleep when they're dead. I have a nice graph that poor sleep is associated with increased mortality. That was not our talk today, but sleep is important. I did not want to put a picture of alcohol up here, so don't gamble. Don't play with risky substances. Don't text and drive. Be smart. Thank you guys so much for your attention, for coming today. It's been a pleasure to be here.
Well, Thank you, Dr. Bonas, for a very excellent, invigorating talk. On behalf of the College of Health and Human Sciences, I'm pleased to present you with this little memento for you to take back. It's rather heavy, but it's really, again, our appreciation for being our Career Impact Award winner. So thank you. Again, please express appreciation for Dr. Bonas.
Thank you.
So again, we do have time for some questions. There's a mic in the back. If you would, please just raise your hand. You can, and we'll circulate the room in terms of that mic. Brother? I'll let you say it.
Oh, okay.
Hi. So your presentation said a lot about like all the benefits of healthy diet, healthy eating, stuff like that. I was curious about like the disease state individual, because I know there's a lot of disease states out there that really blunt the positive effects of healthy eating. Would the solution to that for them be eating more, or is there like a negative effect to like overconsumption of these fruits and vegetables and stuff?
Yep, perfect. So it depends a little bit on the disease state, right? And so there's different guidelines for different disease states. And so is there a specific disease state you have in mind?
Not one in mind. I know the one that I've worked with a little bit is peripheral artery disease. And how we treat it with sulforaphane. Because sulforaphane reduces the ROS species with and inflammation.
Yeah. And so, again, I tried to keep it broad, right? Because the dietary guidelines for Americans and a lot of these guidelines are based on the general population. And so as we get into specific disease states and as we get into individual medications, certain medications or drugs may have specific guidelines. There's a lot of drugs that may have drug-nutrient interactions. And so grapefruit is actually a common one. Grapefruit, I believe, activates the CYP2A system, and so can cause different metabolic pathways for certain, and impacts the pharmacokinetics of certain prescription medications. So if you're on certain drugs, you're not supposed to eat grapefruit because it impacts the metabolism of those things. And so I will be honest, I don't use sulforaphane very much in my practice, and so I'm not sure about specific foods that may or may not interact with that medication. But as we think about peripheral artery disease in general, it's generally going to be associated with cardiovascular disease. And so generally it would be recommendations regarding a cardiovascular diet to try to reduce the associated risks of the cardiovascular disease. But we may need to certainly pay attention to other medications or things that patients are on to make sure that we're not causing what we would call drug-nutrient interactions. So there are actually programs that you can put in medications and get guidelines as to what certain foods you may need to avoid or be cautious of because of the specific metabolic pathways that they activate or not. There's a whole field called pharmacogenetics, and so even outside of nutrients, you can have genetic testing done to look at your metabolic pathways and see if you are at risk for being a high metabolizer or a low metabolizer, and if you need specific dose adjustments for your medications. And so that may tie in even more with how nutrients may interact with your specific prescriptions.
Question over here.
Yeah.
You mentioned at the beginning of your talk that supplements weren't a good idea to manage your health. I was just curious to see what supplements, in your opinion, are the biggest waste of money.
I don't know that I have a specific one in mind. I don't know that I have a specific one in mind. Most of them are going to be water soluble, and you're going to just pee them down the toilet. That was probably not officially what I was supposed to say, but.
When you were talking about risky substances, you mentioned nicotine specifically.
Yeah.
And so I'm sure you're well aware of the current trend for nicotine pouch use. And I'm wondering if you can comment on your perception of that trend, what specific risks you think or know are associated with that. And obviously the conversation there separate from tobacco use, focusing on the nicotine use specifically.
Yeah, and I'll be honest, I'm probably not as well versed in all of the exact nicotine literature, but I know that nicotine has certain vascular effects and that impact a variety of different profiles. And so nicotine is associated with just nicotine itself, certain adverse health outcomes in different populations. And so whether it be certainly I would advocate for nicotine in the event that it is nicotine replacement therapy to stop tobacco or to stop cigarette smoking. So I do use nicotine in that situation. But I do not advocate for other forms of nicotine to try to use it in those contexts or for long-term nicotine use in other pouches, other supplement therapies. But yes, absolutely, if nicotine is used in a controlled therapeutic setting, right, particularly to stop smoking or other recreational use, I am a strong advocate to try to stop those other behaviors.
So just to be clear, you don't recommend nicotine use to enhance cognitive function in college-age students?
To be clear, I do not recommend nicotine use to enhance cognitive function in college-age students. I recommend strongly sleeping 7 to 9 hours a night.
For someone who's already in a diseased state, how would nutrition provide relief to that individual?
It depends very much on the disease state. And so there's a lot of different disease-specific state guidelines, and it really depends on that different state. And so there are different guidelines for heart disease versus kidney disease versus Crohn's and colitis versus celiac disease versus some of the autoimmune diseases. There's a specific talk about the Mediterranean diet or other things like that. So it really depends on the disease state as to how the diet may need to be or may be adjusted to try to help manage that specific condition. I know that was vague. I'm sorry.
Thank you, Dr. Barnes. You spoke a lot about the composition of the diet. What about the caloric intake? And can you comment specifically, please, on the calorie 1, calorie 2 trials? You know, the work of Susan Rossett has shown, you know, over the 6 months to a year that they've been running, my understanding is that they've actually slowed some of the demarcators of the aging process. What do you think of that?
Yeah. I struggle a lot with the caloric restriction trials. I think caloric restriction is a challenging one to talk about, and in part I talk about it a lot with my patients because A, it's a very common topic, right? Here in this forum, when I meet with patients, we do bioelectrical impedance with an estimated resting metabolic rate on pretty much everyone. When I get an estimated resting metabolic rate on almost every female, their estimated resting metabolic rate is about 1,200, right? Dietary guidelines for Americans for a female are 2,000 calories. How many people in here wear an Apple Watch, a Garmin, et cetera, and how many people get 800 physical activity calories? You guys are college students for the most part. I'm talking about 50-year-old business women. They are not going to be burning 800 calories a day. And so I personally talk about 2,000 calories a day is probably going to promote weight gain for all of these people, right? And so we need to significantly reduce from there. And so what are your true caloric needs there? But then as we talk about calorie restriction, a lot of the discussion in this space is it's a limited time period. And as we get older, we already are going to have lower amounts of muscle mass. And so what is the risk of frailty, et cetera, as we progress in age as humans with these other factors? So certainly from a physiology perspective, there is potential benefit. As I go to longevity conferences, there's more and more folks actually microdosing GLP-1s as opposed to doing calorie restriction. And I'm not sure if it's because it's easier to microdose a GLP-1 than it is to truly restrict, or if it's because of the just limited data that we have in adults, or we also get into what's borderline eating disorder. We are starting to see more with what we call orthorexia nervosa. So obsession with eating healthy. So we have anorexia, right? Just the medical diagnosis of limited eating, disordered limited eating. But orthorexia is obsession with eating only healthy foods. And so I think as we get into this space, it's a complicated nexus of what is best, what is right, and how do we cross all of these things.
Well, yeah, thank you for that. My thought was that with your mindful eating and slowing down, that maybe that would have some of that effect as well.
No, so I certainly talk about we need to make sure we're eating for the right reasons. We need to make sure that we're not using food as other things, et cetera. But yeah.
Sara, I've got a question for you while I'm moving across.
Yeah.
So speaking on behalf of my behavioral scientist colleagues here, I think everyone in this room they've been well-versed over the years. We need to eat better,
Yeah.
whatever that means. We need to move more. We know that. But as your data points out, and we've heard, we're not doing it. So in your opinion, your advice, how do we change behavior to do that?
I think that's a great question. And I think it really gets to the point that we need to figure out what is the driver for each individual. I don't know that we can do it at a population level. I think it needs to be at an individual level. Because what is my driver probably isn't going to be the same as your driver or motivator. And so that's where having the time to sit down with an individual and figure out, for those in health sciences, we've probably talked about motivational interviewing, right? And it takes time, but it takes trust too, to get to know these individuals and figure out what are their goals and what's important to them, and how do we really figure those things out so that we can help them achieve their goals and set realistic goals and move forward. But I think we've not been successful as we've tried to do it at a population level, and we need to figure out how we can continue with population efforts, but make it personal.
Good time for one more question right here.
You talked about ultra-processed foods and supplements. I think one of the problems with ultra-processed foods are that they're made to be more palatable and less satiating. But what about things like whey protein isolate, generally considered in the fitness circle as beneficial to your diet? What are your opinions on that, and other supplements like creatine even?
Great question. My personal, and You can probably tell from my physique, I'm not a bodybuilder. So take that as you will, but my personal preference is try to do what we can with diet, right? And so balance it out from those perspectives. Now, I'm not trying to get into any bodybuilding competitions and win anything. And so certainly I try to balance what I can with diet and make sure that I am getting what I can from the balanced diet perspective as opposed to supplementing, because I would agree. I think that those supplements are still ultra processed, et cetera. Now, I know if you look at the data, right, then the creatine or those other supplements in the right population may be associated with better muscle mass in addition to adequate protein, your weight training, et cetera, et cetera. So I think you need to talk about it in an individual goal with the right trained person, and the right trained person has the right credentials, not a TikTok video.
Or what about like higher protein diets in older adults as well?
I think it depends on the definition of higher protein. So I do tell my older adults 1 to 1.2 grams per kilogram. And I have a nice graph of, it's not the protein. Protein alone does nothing for muscle mass. It's resistance training, and resistance training with exercise, or resistance training with protein is where we're gonna get the most bang for our buck. But there's also another study that shows like college kids, because you pay college kids enough, you can get them to do anything. College kids on bed rest for 10 days lost 10% of their muscle mass, but you put I think it was 70 or 80-year-olds on bed rest for 10 days, and they lost, a third of their muscle mass. And so the muscle physiology changes drastically as we get older. And so we need to make sure that we're keeping those muscles active as much as we can, especially as we get older.
Thank you.
Mm-hmm.
Okay, those of you who may have a question that you'd like to ask, I'm sure Dr. Bonas will stick around for a few minutes. Please feel free to come down towards the front. Again, there are some refreshments in the back. Again, please join me one last time in thanking Dr. Bonas.